Tell me when we're ready. So good afternoon. We just finished voting, so if you see some of the members get up, they just need to stretch, maybe use a facility, give them a second, they'll be back. They also watch the proceedings offline as well. So welcome to the Health and Government Operations Committee. I'm your chair, Jocelyn Peña-Melnick, and to my left, I'm joined by my vice chair, Delegate Bonnie Collison. We're going to go through some of the rules just quickly. I ask for your patience if we encounter any technical streaming issues. This briefing is being streamed on the Maryland General Assembly YouTube channel. Before this briefings, all members were emailed a copy of each presentation. If you don't have the documents, please let committee staff know, and we will send you the copy immediately. For the committee members, please adhere to our usual committee rules of one question and one answer from the panel, not one question and one answer from each panelist, to keep the briefing brief. After the briefings, we do have hearings. Today, the House Health and Government Operations Committee will hear a briefing on medication-assisted treatment for opioid use disorder in local correctional facilities from the Governor's Office of Crime Prevention and Policy, the Department of Health, and the Office of Overdose Response. We will begin with Brandy Can, Assistant Director of Justice Reinvestment from the Governor's Office of Crime Prevention and Policy. But I also want Bethany Young, the Director of Policy and Legislation, Deputy Secretary for Behavioral Health Administration for the Maryland Department of Health, Alisa Lord, and I would like the Special Secretary, Emily Keller. If you all can come up, and if there are not enough chairs, just bring one more, and please sit together. As soon as you sit, may I have the first speaker, welcome to the Health and Government Operations Committee.
Thank you.
And thank you for being patient as you waited. We are running a little behind, but we had voting before this, and we have hearings after this, so it's a busy Friday.
Busy.
Good afternoon.
Good afternoon.
Good afternoon.
Good afternoon.
If you could also move the microphone closer to you so that we can hear you well, that would be wonderful. Thank you so much. And this is a briefing again on medication-assisted treatment for opioid use disorder in local correctional facilities. Get started.
I shall, Madam Chair. Good afternoon, Chairwoman Peña-Melnick, Vice Chair Collison, and members of the committee. On behalf of the Maryland Department of Health, the Maryland Office of Opioid Response, and the Governor's Office on Crime Control and Prevention, we thank you for the opportunity to present on the Opioid Use Disorder Examination and Treatment Act and provide an update on the status of House Bill 116 that passed in 2019. According to JAMA, in 2023, more than 80,000 individuals died from an overdose involving opioids. In Maryland, in 2023 and 2024, there were more than 2,500 fatal overdoses in the state, with almost 2/3 of the U.S. jail population experiencing a substance use disorder. Jails and detention centers can provide life-saving treatments such as medications for opioid use disorder, otherwise known as MOUD. House Bill 116 was can we go to the next slide? Thank you. I want to set just some context for this at both the federal and state level. House Bill 116 was at the forefront of adhering to federal requirements of the state to ensure that, as outlined in CFR Part 42, Part 2, and Part 8, prisons provide access to MOUD. This is further buttressed by the Title II of the American with Disabilities Act, as well as the 8th Amendment, which guards against jails showing deliberate indifference to medical needs, inclusive of the access to treatment for substance use disorders. Can you go to the next slide, please? When House Bill 116 was passed, there were several tenets, including the provision of FDA-approved medications to treat substance use disorders, additional support such as counseling and peer support, ensuring the development of re-entry plans as part of safe discharge and aftercare, and data and reporting. What we have found is that over the, can we go to the next slide, please? Thank you. What we have found is that over the years is that while there are similarities across models of MOUD and detention centers, there is wide variability of adoption and implementation. For all, detention center screenings are happening, but what transpires after the assessment may not always be consistent. Many detention centers are referring to the medical unit. Some are contracting with outside providers, and some are contracting with providers to render on-site or virtual care. Some are electing to become a licensed outpatient treatment program, or OTP, rather than outsource. Some are electing to transport to outside providers. Correctional staff may be engaged throughout the various processes, regardless of the model. Now that we have set the stage of the federal and state requirements and some of the key elements that comprise a model of MOUD care in detention centers, I will turn it over to my colleagues in GOCAP to walk us through data elements that they have collected as part of the reporting requirements.
Thank you. Good afternoon, Chair Peña-Malnick and members of the committee. My name is Brandy Kahn, and I am the Assistant Director of Justice Reinvestment at GOCAP. I'm going to talk about some of the data from our fiscal year 24 report. So GOCAP is responsible for collecting and analyzing the data related to this legislation. The law requires us to report out on 17 different data metrics, and we recognize that data collection can be burdensome on our local jurisdictions. So I want to take a moment and talk about some of the why this is important for our data collection. Our overarching goal is to measure program effectiveness to ensure that we are providing meaningful interventions. We want to make sure that our local detention centers are providing the appropriate standard of care for individuals in their custody. We also want to track individuals as they move through the criminal justice system and identify barriers that we can address to improve those systems. And finally, we want to make sure that we're informing future policy and funding decisions, which we've been able to do over the past few years. Slide. So from our fiscal year 24 data report, we received data from 23 out of 24 jurisdictions, representing approximately 11,000 individuals who entered into correctional facilities between July 1, 2023 and June 30th, 2024, who were diagnosed with a substance use disorder or mental health disorder. Among these individuals, 6,225 were diagnosed with an opioid use disorder, 5,598 were diagnosed with a non-substance use disorder, and 7,052 were diagnosed with a mental health disorder. Our data also shows that 4,691 met the criteria for dual diagnosis or a co-occurring substance use disorder and mental health disorder. Of the 6,225 diagnosed with OUD, roughly 60% received medications for opioid use disorder. Approximately 1,800 individuals received buprenorphine, 1,900 received methadone, 15 received naltrexone, and 33 received some unspecified treatment. This slide goes into the continuity of care a little bit. According to our data, 30% of individuals diagnosed with OUD had been receiving some kind of treatment before incarceration. 78% continued with the same treatment while incarcerated. 58% of all OUD diagnosed individuals were prescribed MOUD, and 90% of them initiated treatment. These tables represent the breakdown by treatment, including the medications prescribed. Thank you. This slide references some of the treatment retention and reentry planning. 5.2% of individuals on MOUD discontinued treatment while incarcerated. On average, incarcerated individuals received treatment 74% of their time in custody. The average length of stay was 54 days. The average length of treatment was 50 days. And according to our data, 2,980 individuals received MOUD before release, but only 40% of those individuals had documented a reentry plan, which highlights a critical gap to post-release support. All of this data is available in our newly published report, which we're happy to share with the committee. We've also launched a data dashboard on our website that I'd also be happy to share to increase transparency.
Good afternoon, Madam Chairwoman and Committee. My name is Emily Keller. I'm the Special Secretary of Overdose Response. This implementation progress shows what our overdose prevention teams self-report. We call them OPTs, and they are generally in charge of the health department and several other entities that make this group up. This is self-reported information, but as you can see here, the majority of jurisdictions have reported substantial implementation when it comes to MOUD in jails.
Good afternoon. My name is Bethany Young. I'm the Director of Policy at GoCap, and I'll be talking a little bit about challenges to implementation or areas of implementation where we are not quite at 100%. So I'm going to start with the data as a challenge. As you know, Brandy just went into that detailed, Brandy and the Special Secretary detailed description of the data that we've collected so far. And the information that I'm going to share with you today was collected through various TA, technical assistance opportunities, that GoCap has provided, supported by our consultants at the Health Management Associates. And so we were able, kind of through those various interactions with local correctional facilities, to surface the following obstacles. So starting with data, we've heard and observed and experienced some difficulties tracking and reporting data. So for the counties themselves, GoCap does this in a variety of contexts. We frequently receive, synthesize, and report out on different criminal justice processes. And it can be difficult for our local criminal justice agency partners to comply with the statutory requirements as it relates to data for a number of reasons. As all of you know, I'm sure, many of our criminal justice agencies are facing capacity challenges. And so kind of data, which is kind of not typically, it's kind of its primary function, it can be difficult to comply with reporting requirements. And for this bill in particular, it is, as Brandy mentioned, I think there are 17 distinct metrics which are required to collect, and some of them are complex, so that can be a challenge to our partners in the counties. Challenges for GoCap in synthesizing and reporting out on the data kind of have been related to the challenges we're seeing at the local level. So we may get data late or incomplete. As Brandy mentioned, sometimes we don't get it at all, or kind of in formats that take some time for us to clean, then to be able to report out in a way that's digestible and useful for the public. So, we're always, working to make that process simpler and to improve the data that we keep, but it is something that affects our ability to really accurately and completely track what's happening. Another challenge that we've heard is stigma. I'm going to read an excerpt from our report because I think it captures it really well. Stigma related to substance use still permeates every facet of our society, especially in the correctional community that has historically fought against illicit drug use and is responsible for upholding the laws prohibiting the sale, purchase, and possession of narcotics. Thinking of substance use disorder as a chronic disease requires a radical paradigm shift. And it is something that we, I think I'm safe to say our partners are up for. They're up for the challenge, but it is kind of a cultural shift that has to happen in a lot of places. So when sites who participated in our TA responded to the question about whether they had buy-in from their local leadership, about a quarter reported that they did not have, the support that would be helpful from their leadership. And I think all of them reported that they've encountered some skepticism about the importance of this work. Brandy talked a little bit about the standard of care. So I'm going to, and I think Assistant Secretary Lord touched on it a bit too. I'm going to talk a little bit about kind of where we're not fully in full implementation as it relates to the standard of care. So there is some variance in the tools that facilities are using to screen and assess people coming into their custody. There are evidence-based tools to do that, and there is some variation in the extent to which those are being used by the locals. There is some variance. I think most, but not all, are providing all 3 of the required FDA-approved medications. Not all of the facilities are offering harm reduction tools, so things like naloxone, fentanyl, and xylazine, test strips. And then another area related to the medication aspect of the requirements are about kind of barriers to providing access to treatment. So RTA partners observed that some of our local partners, for example, might require someone to participate in talk therapy before they get access to the treatment. Or some might be waiting to get information from a community provider for those who are already on treatment before continuing treatment in the facility. In terms of the non-medication supports required by the law, some of the areas where we are trying to provide more support to get up to kind of fuller implementation is access to on-site peer recovery specialists. I think that's a challenge that many of our local partners have encountered. Also related to the standard of care is continuity of care, which again, Brandy talked about a little bit. And this really manifests across kind of three different buckets, if you will. So people who are coming into the facilities already receiving treatment, people who are in local facilities awaiting transfer to state prisons, and people as they depart jails and prisons. So I mentioned, a minute ago, people who are already receiving treatment, there may be some delay in, what a local detention center thinks they need to be able to continue treatment, which presents an obstacle in some cases. And I'm happy to report on the second group of people. So those who are in local facilities awaiting transfer to state facilities, we've made a good amount of progress recently in this. So for some time, it was the case that someone who was in a local facility awaiting transfer might never receive treatment, knowing that they'd have to be moved later, or initiate treatment and then have to be withdrawn from the treatment, which presents its own health risks, which is, and neither of those are the scenarios we want for the people in facilities. So with partnership and grant funding from GOCAP, the DOC now does offer continuation services for individuals who are entering state facilities and already receiving MOUD. And I believe you received some information from DPSCS about the status of the treatment they're providing with some specific data on the number of people that they are now able to serve. And then as has been mentioned, another key component of the Act is reentry planning. And that's an area where we're short of full implementation. So to varying degrees of wide variation in terms of the support that's offered to people as they're leaving the facilities. And it can range from maybe getting some information on paper to what we really like to see, which is a warm handoff where someone is kind of delivered into the hands of community care or people who can help them access that. And that's things like insurance, actual treatment, getting a prescription, the peer recovery, again, as well as behavioral health counseling services. Last but not least, in terms of challenges is the funding piece. I think you all have probably heard or will hear a lot about this in other settings, but that's something that's been reported to us as a challenge for our local partners is navigating the multiple funding sources to comply with this mandate. They've experienced some difficulties in that piece of it, but I think all of us will talk a little bit later about the funding that we have made available and provided to support the locals in full compliance.
So Bethany mentioned a little bit about the technical assistance our office was able to offer to increase compliance of this act. So I just want to go into that a little bit. In fiscal year 23, we offered our most robust technical assistance. We were able to provide on-site coaching through health management associates to each facility to tailor their needs, because we know that what works in Anne Arundel County might not work in Queen Anne's County. We also hosted weekly interactive webinars, and we covered a range of dynamic topics, telemedicine, data collection, the legal requirements associated with MOUD. We hosted an all-day in-person learning collaborative and provided sessions on best practices for compliance. And then lastly, which I think is, one of the most important pieces of this, we provided $350,000 in participation stipends for facilities that were engaged in RTA to help offset the cost of running these programs. In fiscal year '24, we hosted monthly ECHO sessions, which is a case-based learning model. This helped our detention centers to learn from each other and from subject matter experts. HMA also was able to help our health department and DPSCS on guidance for Medicaid waivers, helping the state address federal regulations that prohibit Medicaid use for incarcerated individuals. And in fiscal year '25, we are working on a behavioral health landscape analysis in all of our correctional facilities. So we'll conduct thorough interviews with the correctional administrators and wardens to help us target grant funding and address ongoing challenges. So as far as GOCAP funding, we have 2 available funding sources to fund these kinds of programs. The first of which is a federal funding source, the Residential Substance Use Treatment Grant. This is a block or formula grant that we get from the federal government. It's available for state, local, and tribal correctional detention facilities. And funds can be used to create and maintain reentry services and any kind of substance use treatment programs. And then we also have Justice Reinvestment Grant funding. This is state funded, which is generated out of the Justice Reinvestment Act and can be used to support behavioral health programming for justice impacted individuals. So approximately $4 million since inception of this Act's passing is what we've invested in our local detention centers.
Regarding the Behavioral Health Administration, we've looked to diversify the various streams of funding to ensure that we're not solely reliant, and also as outlined in the legislation, the department is required to pursue federal funding. So what you see outlined here are the 3 main sources of support for MOUD and detention centers, and this also includes some of the linkages for aftercare as well. So state opioid response, which is our federal funding through SAMHSA, the Substance Abuse Treatment Outcomes Partnership Fund, which is state funds, and then separately, we also receive requests through our annual allocations process with our jurisdictions to support these efforts. What you'll see here on the next slide is in fiscal year '24, the Behavioral Health Administration administered grants that range from $27,000 to $1.2 million to 16 jurisdictions for the total amount awarded at more than $7 million. For fiscal year '25, we've increased our investments with the total amount awarded in excess of $11 million to 17 jurisdictions, and the grants range from $67,000 to $1.3 million.
And for Maryland's Office of Overdose Response, for fiscal year '25, we did have competitive grants through the Opioid Restitution Fund. We awarded about $2.2 million across 5 jurisdictions. For fiscal year '23 and '24, we had the Examination and Treatment Act Grant Program, also through the Opioid Restitution Fund. There was about $7.7 million awarded across 17 jurisdictions. And then we do have competitive grants, which is state general funds. In fiscal year '20, we awarded $78,000 to 2 jurisdictions. Fiscal year '21, $122,000 to 2 jurisdictions. Fiscal year '22, about $435,000 to 2 jurisdictions. And fiscal year '24, $181,000 to DPSCS. So moving forward, all 3 of our departments are going to continue to provide grant funding. We also have the Medicaid 115 waiver. MDH recently received CMS approval for reentry services. This allows Maryland to provide targeted Medicaid services for incarcerated individuals who have substance use disorder or serious mental illness up to 90 days pre-release. That includes comprehensive case management, medication-assisted treatment, and counseling and prescribed medication for up to 30 days post-release. GOCAP intends to work with local detention centers on readiness assessments and implementation plans for when they're able to access these benefits. And we do have an interagency coordination. We're committed to work with MDH, GOCAP, MACO, and the Maryland Correctional Administrators Association to work towards solutions. It's certainly not our intention to make the grant process difficult. We look forward to continuing the conversation that we started.
I think those are all the slides we have.
Yes.
So I'm going to open it up for questions. I usually wait to the end to make sure maybe they ask them. So I'm going to open it up for questions now from the committee. Delegate Gorman and Delegate Taveras.
Thank you so much for being here today. I don't know if you guys are the right people to ask, but this came up to me as you guys were giving your presentation. How do correctional facilities manage cases where an incarcerated individual has a legitimate medical need for an opioid-based pain management? And are there any protocols in place to balance the medical necessity with, concerns about misuse? And this is for anybody that could answer. Thank you.
I think I would defer that question to the detention centers.
Thank you. It's so good to see you guys again because we've been in a lot of conversation over the last couple of weeks. Are the people that are incarcerated, are they treated separately from the main population at all, or are they vulnerable to what's happening inside the jail?
Again, I think I would defer that to the detention center as to how they've established the model of care within their facility to render MOUD.
Okay, so then I'll substitute that question for, we're recognizing that methadone and these other opioid-related drugs, they're also addictive, correct?
Can you clarify the question in terms of the MOU?
The treatment for opioids is with the use of methadone.
That is just one of the various different.
You listed 3.
Yes.
And they're all addictive.
I would just say that we all do consider MOUD like the gold standard of care when it comes to treating opioid use disorder.
Any other, Delegate Chisholm, followed by Vice Chair Collison.
Thank you, Madam Chair. I want to ask about the funding, because I'm looking at it, and there's the Residential Substance Use Treatment Grant from the federal, and then the Justice Reinvestment Grant funding from the state. And in the Justice Reinvestment Grant funding, it went from $286,000 to $2.198 million in 2025, and in FY24 in residential substance use, it went from $45,600 to $631,000. Why that huge jump up? And I just want to make sure I understand. That's money that you guys are taking in, or is this money that's actually been paid out, or is this how you're funding the programs?
That's money that's been paid out through those grant programs. And I think that the big jump, especially with the Justice Reinvestment portion of that funding, has to do a lot with like my relationship with the local detention centers, making sure that they're aware that this funding is available for them to use for this programming.
So if I understand FY25, because of your relationships, you educated them on the money being in there, so you took the money and made sure that you sent them 2.198.
Correct.
And how much oversight do you, I know you guys have said maybe that's a good question for the detention center. I don't think the detention centers are here today, but do you know how they're using the money? Or is it, what were they doing before and what are they doing now to have this huge jump up?
Sure. I mean, we receive performance measures every month or every quarter. So we know how they're using the funding. They're using it for staffing and for the medications themselves.
So part of that big jump up, I'm sorry, Madam Chair. So the big jump up could be for the actual drug itself that they weren't getting in there before?
I think one of the drivers behind the increase is that we were able to reach more counties, right? So, and I don't know the specific numbers, but say we were able to fund like 5 of them in 1 year, we were able to reach more of the detention centers and fund more local departments. So the increase represents that we're reaching more people with funding rather than, and it's not necessarily a kind of changing level of service, which we hope is happening also.
Sure.
But it's likely both.
Do we have access to those performance reports?
Yes, absolutely. We can get those for you. We also created a spreadsheet with every county that we're funding with each grant funding. I think that was supposed to be shared with the committee.
One last question. What's the source of the funds? Meaning, I know some of it's federal grants and the rest is state grants, is that correct?
The Justice Reinvestment Funding is generated out of the Justice Reinvestment Act. So our decline in prison population generates those funding.
Okay.
I'm sorry, you're declining.
The state prison population.
So the fund is
here. Thank you.
Okay, thank you. It was Delegate Vice Chair Collison, followed by Delegate Bagnell. And thank you for being patient as you wait for the questions.
Thank you, Madam Chair, and thank you again for your work. So what kind of reporting is done relative to, I see the medications, but in terms of the programming that goes along and then the follow-up of individuals, do we have information that will guide us in terms of how the program is working for these individuals? In other words, what's the recidivism rate? Do we have that kind of data? And do we have ideas about the best practices that work in the different settings?
So the data that we receive is de-identified. So we don't get,
Okay.
any individual's name or anything like that. So we can't follow them that way. But based on the data that we do receive, we can tell, who is continuing their treatment, who stopped treatment, if they change treatments. And again, going back to that statistic about reentry, are they receiving any kind of reentry support? Are they receiving that warm handoff that Bethany mentioned? So we are able to, report out on those statistics.
So are they followed after into reentry, and so that we get information? We don't have to have individual information, but we don't have any way of knowing whether they continue treatment or whether they, become more stable. We don't have that information, right? Okay. All right. Thank you, Madam Chair.
Thank you. Delegate Bagnell.
Thank you, Madam Chair, and thank you for being here. And I think we're all trying to sort of get to the same question, which is that relationship between the Department of Health, MOOR, previously OOCC, GOCAP, and then the Department of Justice. Because we often talk in this committee about that continuity of care. And the question is, if we are leaving everything to the correctional facilities, who aren't here today to answer these questions, so I apologize that these may be challenging to answer. What is the department's responsibility in ensuring that those services are being provided, that they are that we are measuring outcomes? If there are measurable trends, like in a reduction in violence and a reduction in opioid use disorder, and is there, how can we do that better? And is there an opportunity to have like a voluntary program at pre-release so that we can continue that continuity of care and we can actually see if the outcomes are following our incarcerated community in reentry?
Appreciate the question, Delegate Bagnell. On behalf of the Behavioral Health Administration, I can say a couple of the things that we're tracking. So we are tracking the number of individuals that receive MOUD through our programs. We are also tracking overdoses. once released into the community, because we do think that the aftercare piece is critically important so that they maintain access to services. And then I think with the reentry waiver, which will go into effect July 1st, that will allow for case management up to 90 days prior to release. So in terms of that continuity of care and transitions of care into the community to ensuring that they're being connected to services, that should create greater bandwidth for addressing some of those concerns.
Okay, I don't see any more questions. I do have, oh. Who? Oh, Delegate Hill, sorry. Did you just put it on or did I miss it? Okay, I apologize. Maybe I did it purposely, just kidding. Go ahead.
I guess this is to Deputy Secretary Lord. I'm sort of following up on Delegate Bagnall and Vice Chair Cullison's question. I'm seeing all these numbers, and I have no idea what this means. I have no idea if we're doing good stuff, we're not doing good stuff, if it's making any difference, it's not making a difference. I, was part of the Justice Reinvestment and taking those cigarette funds and pre-investing. We knew it would take 7 or 8 years before we could see that by identifying folks with behavioral health and addiction problems early on and addressing that and diverting them, that we could see outcomes right around now. And I'm not sure we're seeing any outcomes. Can you tell me how you interpret this data? Is this making a difference? All of these slides.
Which slide are you referencing?
I'm looking at the continuity of care slide. I'm looking at the treatment, retention, and reentry planning. And I just see statistics that don't tell me, what's your conclusion? Are we on the right road here? Is this stuff we should be doubling down on? Is this making a difference?
Well, I think it's a standard of care that's critically important for individuals that are in our care and custody within the state. This is no different than offering somebody who's a diabetic metformin, right? I think there's work, and I think this was alluded to by our partners in GoCap, that there is still such stigma attached to accessing care for a substance use disorder that there is work that we need to continue to do to be able to support individuals accessing those services and treatment. I think we are heading in the right direction. We're seeing our overdose numbers in the state of Maryland come down, and it's in part because we're building out this broader continuum. So while they may not have access to care prior to going into the detention center, once they're there and making sure that those screening and assessments and connectivity to care is happening is critically important. I think where you're seeing on some of the data where we need to improve is in that transitions of care back into the community to make sure that they are getting access to services. And it's deeper than just behavioral health services, right? So it's making sure that they have housing, employment, reconnectivity with families and friends, or establishing a community that they feel safe to come home to. So it's much bigger than are we moving the needle, but I do think we're heading in the right direction.
All right, that's really helpful. And if I can just do one follow-up. I don't see any information, maybe we don't track it. Do we have any sense of how many of our incarcerated folks are getting addicted while in? That they came in without an addiction problem, but became addicted during their time of imprisonment?
It's a good question. We are not capturing that data. I don't know if GoCap or more are.
No, we're not. Okay, all right. Thank you.
Questions? Seeing none, I'm looking at your FY24 data slide, and it states that there were 11,046 unique persons who received 18,875 unique diagnoses during incarceration. Out of that, 7,052 had a mental health disorder based on the above diagnosis, right? And 4,691 incarcerated individuals met the criteria for dual diagnosis. those that have a mental health disorder, can you tell the committee, if you know, what kind of treatment do they get?
Well, part of this act requires behavioral health counseling services. I think that's another great question for the detention centers, but I know that those services are being offered in our local detention centers to help address any kind of mental health disorder.
Okay, but is it safe to say that they're not left untreated, that they're offered some type of treatment?
I think so, but again, I think that that's a good question for
Okay, all right.
locals.
And we'll do that. Do you communicate at all with the local detention centers? Can you ask them the question, please?
Sure.
That the committee would like to know what kind of treatment is provided, for example, for those 7,052 people that were, found to have a mental health disorder, right? Whether it's counseling, peer group support, medication, what is offered? If you could get that to the committee, I really would appreciate it. And if you want, you can CC my Gmail address. That would be wonderful, okay? I think what is clear from looking at this data is that we have a lot of people that have some serious issues in our state. To lose between 23 and 25 over 2,500 people, that's a lot of loved ones, right? It's a lot of chairs that are empty at a dining room table, right? And we need to continue to try to figure out how to treat them. It is easy to treat them when they're outside, right? But when they're inside, we have to be creative and think outside the box, because eventually those people will come out, right? And we need to start the treatment early so they can continue it outside as well. Because otherwise you have a high recidivism rate because you have not treated the underlying issue as well. I know that there's a lot of differences in ideology regarding, for example, not that I'm picking on them, but the public defender's office does not prefer that in the prisons, right? That the incarcerated individual receive that type of treatment or medication. And I think that we must get to a point where we can all sit down and try to figure this out. Because it's better to have some treatment, in my opinion, than none as well. And over the years, we have seen so many people that have sat there where you are. They have lost loved ones, and they start their testimony with a picture. And it's something that could have been prevented, right? So all these medications that are being used do prevent it, right? But we need to keep thinking outside the box and working together at it. So I thank you for the work you do, and thank you for this presentation. It was a lot of numbers, and I'm sure people will digest it as well later. But thank you for caring and for keeping the data. The data is so important because it will guide our policy decisions. And the data does not lie, right? Yeah. Thank you so much for coming. We really appreciate you. Hope you have a blessed weekend. And thank you for what you do. This actually concludes the bill, the briefing for today. Conclude these briefings. We're going to go next. We're going to go down for a second. Please don't move. We're going to go straight into hearings, okay? Thank you.